The Ohio chapter of the American Academy of Pediatrics is excited to bring you a presentation today on the Smoke Free for Families pilot QI program. This is a program that helps primary care clinicians reduce infant mortality risks for their patients, and we're excited to have with us today Dr. Michael Gittelman. I want to give you just a brief introduction for Dr. Gittelman, and then I will turn it over to him. Dr. Gittelman is a pediatric emergency room physician at Cincinnati Children's Hospital Medical Center. He is a professor of clinical pediatrics at the University of Cincinnati School of Medicine. He completed his undergraduate work at Swarthmore College and his medical school training at the Medical College of Pennsylvania. He completed his residency in pediatrics at St. Christopher's Hospital for Children in Philadelphia and a fellowship in emergency medicine at Cincinnati Children's. His area of expertise is within the field of injury control. Prior to the formation of a council, he served as the chairperson for the American Academy of Pediatrics section on injury and poison prevention. He is president of the Ohio chapter of the American Academy of Pediatrics, and he is a co-director of the Comprehensive Children's Injury Center at Cincinnati Children's. Dr. Gittelman also serves as the medical director for the Ohio AAP Smoke Free for Me Quality Improvement Program that supports pediatric primary care providers in completing the 5 A's of smoking cessation during infant well visits with the goal of reducing in-home smoke exposure early in a child's life. He is involved in resident education on injury prevention, and he works with high-risk communities in an effort to reduce pediatric injuries. One of his research interests has been to study the impact of an ER encounter and education by a pediatrician about injury risks on promoting a behavior change to prevent injuries. More recently, he has worked with the Ohio chapter to develop a statewide bicycle helmet intervention and to develop an injury QI program for practicing pediatricians. He is nationally recognized for his injury prevention efforts and research, and much of his work has been published in peer-reviewed journals. Thank you, Dr. Gittelman, for joining us today.
Thank you, Kristen. And as Kristen said, we're going to talk today a little about Smoke Free for Families, which is a QI program in primary care offices to help reduce infant mortality risk. I have nothing to disclose. I do want to thank many of our sponsors, primarily the Ohio chapter, the AAP, Kristen and her entire staff for a lot of the work that they've done to make this happen. We also want to thank the Ohio Department of Health and the Ohio Department of Medicaid and the Ohio Colleges of Medicine Government Resource Center. All of them have been substantial in their assistance as well as funding for this project. So we're going to talk a little bit about infant mortality today. And so what is infant mortality? Well, infant mortality is defined as the death of an infant before their first birthday. And the way that it's calculated is it's the number of infants that die divided by the number of live births in a year times 1,000. And these rates can vary by race, by state, and by country. And over the next few slides, you'll see what I mean by the variations. But it accounts for approximately 23,000 infant deaths annually. A lot of health people look at infant mortality as an indication on the health of a community or a state. And the reason why is because the same risk factors that contribute to infant health also affect the health of the broader population. So when you take a look at infant mortality by race, you can see that African American children are 2.5 times more likely to die than Caucasian children. When you take a look at it by state, you can see that our state in Ohio, we have a very high infant mortality rate. It's not as high as a place like Mississippi. However, it is significantly higher than Massachusetts. One of the reasons why Massachusetts has a lower rate is that they have low teen birth and preterm birth rates, and as a result, they have a lower infant mortality rate. Unfortunately, though, when you take a look at infant mortality internationally, the United States does not do very well. When we're compared to many other countries, such as Sweden and Finland and Norway, they actually have very low infant mortality rates, where we have very high infant mortality rates, which means that there's something that we should be able to do to try and reduce these rates. So since we're talking about infant mortality, let's talk about some of the causes of infant mortality. So the top 2 causes of infant mortality are congenital birth defects and preterm births. And those are by far the highest rates for infant mortality. However, there's this group called SUIDs, which we're going to talk a little bit more about, but these are the unexplained infant deaths. And so you could see that some things such as pregnancy complications, suffocation, sepsis medical, those all account for about 20% of deaths. However, there's this other category, which is kind of undefined, which comes to about 32%. And as a result, the SUIDs deaths could be up to about 52% of deaths. So let's look at, many of you know what SIDS is. Let's look at SUIDs versus SIDS. So SUIDs is sudden unexpected infant deaths. So these are deaths of an infant less than 1 year of age. And so these are deaths that even after the medical examiner has done a report, they can't determine whether it's SIDS, suffocation, or some other cause. So these babies die suddenly and unexpectedly, and it accounts for about 3,500 of the 23,000 baby deaths annually. And you can see in the little grid over to your left that SIDS, trauma, asphyxia, entrapment, infection all make up SUIDs. SIDS is a very small component of SUIDs, and these are sudden infant deaths. It's just one type of SUIDs, and these are deaths that cannot be explained. So clearly it's not suffocation or infection, and we have no idea why this happened, and so it's a smaller subset. So when you take a look at, well, what can we do to prevent infant mortality? Well, one is affect preterm births and try and reduce birth complications on infants. But those are things that happen in the preterm aspect of life. But once a baby's born, what is it that we can do to reduce infant mortality? Well, one thing is there are some children that are vulnerable, such as they're born with complications, which is going to be very hard for us to affect. There is that critical period of development where a kid's developing in the first 6 months, where those are, it's just a child and the way they develop is based on their genetics. Those aren't going to be ones we're going to be affect. However, we are able to affect the environmental stressors. And the two largest environmental stressors that cause a problem to children is one, their sleep condition. So they sleep with the parent, and as a result, they have suffocation, or they sleep on their belly, and as a result, they have a sleep problem, or nicotine exposure. And nicotine exposure has been shown to increase the risk of infant mortality. So the idea is if we can address smoking exposure and sleep position, we can actually make a significant decrease in infant mortality rates. So the next part about this program is pediatrician counseling. So what is a primary pediatrician's role in discussing anticipatory guidance? Well, we know that it is a primary role that pediatricians should serve. One is it's a major part of Bright Futures, and two is that we know it's effective. Families actually change their behavior based on discussions they have with their pediatrician. There was a study done in 2013 by Winikoff, and Winikoff showed there was a 20% increase in smoking cessation counseling versus controls. So when families were counseled, they actually changed their behaviors. We also published a paper from the Ohio AAP in 2018, which showed 65% of families at risk for an injury made at least one change in behavior after counseling. So what is the objective of the Smoke Free for Families program? There's three main parts to it. One is primary care providers incorporate a safe sleep and smoking screening tool into every well-child visit for children less than 1 year of age. And we're going to go through this tool later on, and you'll see it's very simple to incorporate. Two is provide counseling and resources to families when warranted. So when risk is assessed, we can then provide resources and counseling. So initially, you're going to be providing less resources and counseling because you're not doing it for anyone. You're only doing it for when risk is identified. And the last part is self-reported behavior change by families at subsequent well-child visits. So by using the tool at subsequent visits, we can actually determine how much less smoking exposure do children have, how many families are quitting, and if they're actually changing their sleep practices with their infant after being counseled. So you can see this just describes our first wave, and it gives you an idea, which we're going to have a similar program in this Wave 3 when you sign up. It's a collaborative which starts with recruitment. So by you watching this video, that's all part of that recruitment. We self-select practices within the state, and the practices are made up of teams, which are a nurse, an administrator in the practice, and a physician. We really recommend that you have all three of these because this is not a standalone one-person project. You will need some assistance. You need to make sure that things are done in a quality improvement fashion within your practice. You will need some support from nursing or physician assistants. This isn't a standalone thing, so keep that in mind when you sign up. We send out flyers, phone calls, emails, which is probably what you've received, which is making you now watch this video. We will have a learning session. So this learning session was held in January. Your learning session will probably be sometime in the end of September. We will make sure that you know this date as you sign up. If you cannot attend the learning session, we will find a way for you to watch or learn the information to make this as stress-free as possible for you. During that learning session, you will learn about more of the objectives, you will learn what the tool is, how to use it, and you will learn all the resources that we have available. Another part of the collaborative is there will be monthly action period calls. So you will participate on a call. During the call, we will review not only your data, but aggregate data of the collaborative. The reason why this is really helpful is that you can see some of the successes and pitfalls that you've had, but then you can learn from some of the other practices to make your practice even more successful from a quality improvement standpoint. We will discuss the different plan, do, action cycles that we have, and that these cycles will be basically what you're putting into place to be able to improve your quality improvement aspects. Lastly, you will receive a 15-minute lecture on some topic related to smoking cessation, such as vaping, infant-safe sleep, etc. We found that by receiving specific lectures that are very short and targeted, it really increases your knowledge, and by having your knowledge increased, you are more apt to have conversations with families. Last and not least, by participating in this QI program, you will receive 25 points at MOC4 credit, and this is a very simple program that you'll receive this credit, which will help you for maintenance and certification. So we talked a little bit about the screening tool. Let me just go into it a little bit more depth. The screening tool is front and back side of a page. It is a Scantron sheet. The Scantron sheet, once it's filled out, you actually just put it into the computer and you are done with it. You do not need data capture. Our team does all of that for you. Even if you're having struggles with this, we have practice coaching where we have Kristen, who is our program manager, will come out and be able to help your practice to get through this. But the tool, the makeup, is basically some demographic information about the family. We screen for smoking and sleep behavior. We quantify the smoking that they are exposed to, and then we talk about the discussions and resources that you're having with the families and the referral to our Ohio Quitline program. As I said, we collect the data by looking at the screening tool, and it's recorded for every visit. This data sheet is really easy to scan in. As I mentioned, we have some practice coaching, and we will document provider counseling and resources on the tool itself. And then we do some analyses where we calculate the frequencies of the tool use, the discussions, the resources, the percent of smokers, and the percent of safe sleep at risk. And then we also will show you the repeat visits to kind of tell you how you're doing as a practice. This is really nice. This is what we'll be discussing during the action period calls so that you can actually see that, boy, where are we compared to other practices? What are we doing with counseling? How are we providing resources so that everyone's pretty much at the same level? Just to give you an idea of some of the results that we're going to collect, these are results from Wave 1, and we are very proud of these results, and we know that your practice can have similar results. So in our first wave, we had 14 practices made up of 60 providers that participated. These practices varied from 72% were private practices. Some physicians were very young, very small practices. Some of the practices were very large practices. Only about a quarter of them were hospital-based. About 2/3 of them, two-thirds of them were in suburbs, and about 1/3 were in the urban setting. And baseline smoking screens by pediatricians, we found that about 71% said that they screened initially in our pre-survey, But when you asked about where they were smoking, or you asked about smoking, vaping, or other forms, that it was much less done prior to participating in our program. When you take a look at the demographics, just in our first wave, we had about 7,200 screens completed, which is pretty significant because you can get a lot of data with that many screens filled. Now, of those screens, about 4,000 of these screens were the initial visit, and then the other ones were second screens, third screens. And what we found was the average age of the child was about 4 months, and the majority of kids were Caucasian. The families, the parent that was the caregiver was between 25 and 35 years of age. They were the mother, and we found about 40% were Medicaid insurance. So you can take a look at your practice and see kind of where you would fit in, and you might have more Medicaid population, you might have more African American families. It really doesn't matter. This is just a summary of what we found in the Wave 1. When you take a look at use of the screening tool, just in the top left corner, screening tool uptake. I mean, within the first 2 to 3 months, the tool was used close to 90% of the time. So this is something that once you put it in, it is very simple to put into practice, and it's very easy to sustain in practice. Some of the things that you might find more difficult that we will be pushing is the ability to have conversations with families and also provide resources. So we have to make sure that when a risk is assessed, that we are very confident in being able to have these discussions with families. We're hoping in our third and fourth waves that we can get a little bit higher of discussion as well as providing resources. But you can see that some of the changes that practice has made are that they had a culture to comprehensively screen everyone. There was a teamwork effect, so there were huddles, there were pre-visit planning sessions. They had visual reminders where they would put a dot and say, boy, this is someone that you would need to speak with. They had a problem list for documentation on how do we get families to understand what some of the resources are. And almost every practice we spoke to said that they felt much more confident in having these discussions, so they were more apt to have these discussions with families. But if you take a look at some of our results, which is really interesting, we found that practices screened for at-risk families. And so in the initial screen, about 8% of caregivers said they smoked, but about 12% of caregivers said that another person smoked in the house. So we had close to 20% smoking exposure to these children. We also found that 27% of families were placing their children in unsafe sleep environments. Now, when we take a look at it, as we said, we would love this to be 100%, but we understand that there's things and struggles within a practice. But we did have about 72% of smokers were counseled by their pediatrician, 68% counseled about others smoking in the home, and about 64% were counseled about their safe sleep practices. But really what we found, which was exciting, was of those that were counseled and had a repeat visit, we had a 45% reduction in smoking. We had about 20% that quit smoking, and we had about 45% change their sleep practices based on counseling. So anytime that you think that the counseling that you're doing isn't making a difference, look at this. You are making major changes to a family to enable them to change their practice to make their child safer in the home. The other thing that we were excited about in our first wave was we looked at sustainability. So after the practice participated, do they continue to participate? So we did a 3-month post-collaborative survey. We found that every site continued to screen for smoke exposure. Most sites incorporated some of the questions into their EHR, or they just used some of the questions that they felt was most successful. We found 90% of sites continued to refer to the Ohio Quit line, and 75% of sites expanded their screening to other populations. So they weren't only screening for the less than one population, they were screening for older age children. And some of the hospital-based setting programs actually started to screen in their OB offices. They started to screen in the adult setting, in the adolescent setting. So it was really nice to see that this program, which started just in one area, a lot of practices rolled with it, but everyone was continuing to use some aspect of the program. So in conclusion, families with children less than 1 year of age are at risk for smoke exposure and unsafe sleep practices in their home. Participation in our Smoke-Free for Families program, not only do practices get MOC4 credit for participating, but we increase screening and counseling of smoking and safe sleep. The tool is really easy to use. Anyone that tries it, we're happy to share it with you now, but utilizing this tool is very simple, and participation in this tool, in this program, is very simple. But what you really should be most proud of is by putting this simple tool into practice and then having some discussions with families that are really important. Families actually change their behavior, and we're now making kids safer in the home. Not only that, by participating in this program, it makes it very sustainable, and it's something that you're going to be able to use for years to come. So thank you for participating in our this session. We would be happy to answer any further questions for you. Kristen is a really great resource, so I'd urge you to go onto the Ohio AAP website and contact Kristen, or you can email her, or please feel free to contact me. And we really are excited and hope that you will join the program. So thank you for listening today.